It's post-op day 2. You walk in, and your patient is seizing. The lab that just came back tells you why. A sodium of 118. Someone has already hung 3% hypertonic saline on the pump, and your hand is on the roller clamp. Here's the trap this whole episode turns on. Correct this sodium too fast, and you will destroy the very brain you are trying to save. So, here is your question. You are preparing to administer 3% hypertonic saline to a client whose serum sodium is 118 and who has just had a seizure. 4 actions are in front of you. All 4 are things a nurse might reasonably do. Only one is the priority. Which is it? Pause the video right now and commit to an answer out loud. Don't just think it. Say it. 3, 2, 1. The answer is B. Limit the correction to no more than 8 to 10 milliequivalents in 24 hours. Everything here screams for speed. The seizing patient, the critically low number, the hypertonic saline already hanging, and speed is exactly the instinct that harms this brain. Notice what B really is. Not a drug, but a limit. The priority isn't what you give, it's how fast you're allowed to give it. Walk the mechanism with me, because if you understand it, you'll never forget the answer. Sodium is the salt that holds water in your bloodstream. When it falls, the blood outside the cells becomes dilute, watery, and water always moves toward the saltier side. So water shifts into the cells, including the cells of the brain. The brain swells. But the skull is a sealed box, it cannot expand. That rising pressure is what drives the seizure your patient is having right now. You are here. Now the trap. If you flood sodium back in too quickly, you reverse that gradient just as violently. Water is yanked out of the brain cells, they shrivel, and the myelin, the insulation around the nerves, tears apart. That's osmotic demyelination, permanent and often far worse than the low sodium ever was. So slow correction isn't timidity, it's the treatment. And one nuance, when sodium falls slowly over days, the brain adapts, and that adapted brain tolerates a fast correction the worst. Chronic, severe hyponatremia is where demyelination bites hardest. This is the distinction the NCLEX wants you to make. Not every low sodium is an emergency. A patient at 125 to 135 with a headache, some nausea, mild confusion is mild. You have time, and you correct gently. But drop below 120 and add a seizure, and now it's severe and symptomatic. That patient has earned 3% saline. Watch for a dropping level of consciousness, a seizure, or vomiting. Those are your treat now flags. The number sets the stage, but the symptoms decide the urgency. Hold on to 3 steps, and run them in this exact order every time. Step 1. Protect. Before you touch the sodium, protect the patient from the seizure happening now. Airway, side lying, suction ready, padded rails, nothing in the mouth. The seizure can kill before the sodium does. Step 2. Correct but slowly. Yes, you give the 3% saline, but you cap the rate so the sodium climbs no more than 8 to 10 milliequivalents across a full 24 hours. That ceiling is the margin that stops the seizures without tearing the myelin. Step 3. Monitor. Draw a sodium every 2 to 4 hours and watch for overcorrection. If it's climbing too fast, you slow down or stop. Protect, correct slowly, monitor. Now compress all of that into one sentence you can carry into the exam. If it's severe, symptomatic hyponatremia, then correct slowly. Cap the rate, protect the brain. Say it once, out loud. That single sentence answers a whole family of NCLEX questions, no matter how they dress up the scenario. Let's lock it in with 2 you can say out loud. First, your plan. Slow is safe. S, seizure safety first. L, limit the rate. O, only 8 to 10 milliequivalents in 24 hours. W, watch that sodium with serial labs. And the second name's the disaster you're steering around. ODS, osmotic demyelination syndrome, the price of going too fast. Slow is safe, and ODS. Say them both. Now autopsy the wrong answers. Because on the NGN, every distractor is something a nurse could actually do. Option A, infuse rapidly. It's the trap. Seductive, because your patient is seizing and your gut wants the number fixed now. But rapid correction is the exact cause of demyelination. Fast is the wrong instinct. Option C, restrict all fluids and hold the saline. Too passive. Fluid restriction fits milder, chronic cases, but a patient seizing at 118 needs active treatment, and holding the saline removes the very thing pulling them back. Option D, a bolus of isotonic saline. Wrong tonicity. Normal saline won't raise the sodium fast enough for a seizing patient. And this is the one time hypertonic is truly indicated. Every wrong answer was a right action at the wrong time. Tie it into the NGN bow-tie, because this is the shape the exam thinks in. On the left, your cues. A sodium of 118, a new seizure, post-op day 2, 3% saline ordered. In the center, the priority action, 3% saline, rate capped, with seizure precautions and serial sodium levels. On the right, the outcomes that tell you it's working. The seizure resolves, the sodium rises no more than 8 to 10 in 24 hours, no demyelination, neuroexam intact. Recognize the cues, take the action, evaluate the outcome, in that order. Before the next patient, let's put it to work with a quick case. Same patient, 12 hours later. You recheck the labs, and the sodium that started at 118 is now 130. That's a rise of 12 in just 12 hours. And here's the tempting part. The patient is more alert, calmer, looking better. The scene feels like success. So what is your priority action? A. Continue the 3% saline at the current rate. B. Stop the hypertonic saline and notify the provider. C. Give a bolus of normal saline. Or D. Do nothing, because the patient is improving. Pause and choose. The answer is B. Look at the number, not the smile. A rise of 12 in 12 hours has already blown past your 8 to 10 ceiling for a full day, and you're only halfway through it. That is overcorrection, and it's now the thing most likely to hurt this patient. So you stop the 3% saline, and you notify the provider. Now the others. A. Continue at the current rate. That keeps driving the sodium up, straight toward the osmotic demyelination we've been protecting against. The plan was always rate capped, and you've passed the cap. C. A bolus of normal saline. Wrong direction entirely. That adds still more sodium and deepens the overcorrection. And D. Do nothing because the patient's improving. That's the trap this case is built on. Feeling better does not undo the demyelination risk. The danger was never the symptom, it was the speed. So here's the whole lesson in one line. Overcorrection is a medical event. Same rule as before, just pointed the other way. Protect the brain from a rise that's too fast. Screenshot that bow tie before you go, because it's the same unit. And here comes your next patient. Glucose 620, ketones positive, pH 7.18. This one is diabetic ketoacidosis, DKA, and it turns on a question that trips up almost everyone. Fluids first or insulin first? Get the order wrong and you can do real harm. That's episode 3. The free study guide is in the description. I'll see you there.